Chemotherapy for neuroendocrine tumors. When and which regimens? Hello, this evidence-based content is prepared by Saboor, fellowship-trained consultant surgeon. And if you or someone you care about has been told they need chemotherapy for a neuroendocrine tumor, you're in the right place. I know when you hear the word chemotherapy, it's natural to feel anxious and overwhelmed. But today, we're going to demystify exactly when chemotherapy is recommended, which specific regimens work best, and what you can realistically expect in terms of results. Before we dive into the specifics, let's quickly establish what we're dealing with. Chemotherapy for neuroendocrine tumors isn't a one-size-fits-all approach. Unlike many other cancers where chemotherapy is the standard first-line treatment, NETs are more selective about when and where chemotherapy proves beneficial. According to ENETS guidelines, systemic chemotherapy is primarily indicated in progressive or bulky advanced pancreatic NETs and in grade 3 neuroendocrine neoplasms. Chemotherapy for pancreatic NETs is preferably recommended when you have significant tumor progression within 6 to 12 months, higher tumor burden, or clinical symptoms that need urgent control. Now, what does this look like in real terms? When doctors talk about higher tumor burden, they mean substantial disease that's causing problems or threatening to cause problems soon. Not all pancreatic NETs behave the same way. The grading system matters enormously. Grade 1 tumors with a Ki-67 index less than 3% and lower grade 2 tumors typically respond better to other treatments like somatostatin analogs or targeted therapies. But when you're in the upper G2 range, that's a Ki-67 of 10 to 20%, or if you have rapid progression, chemotherapy moves to the forefront. For decades, streptozocin-based chemotherapy has been the backbone of pancreatic NET treatment. The combination of streptozocin with doxorubicin proved more effective than streptozocin with 5-fluorouracil in pivotal randomized studies. Streptozocin has been approved since the 1970s for pancreatic NETs, making it one of the longest-standing treatments we have. That's not because we haven't found anything better, it's because it works, with response rates around 30 to 40% in appropriate patients. The use of doxorubicin is limited by cumulative cardiotoxicity. That means, over time, it can affect heart function, so your doctors will monitor this carefully. An alternative is streptozocin, combined with 5-fluorouracil, which avoids cardiac toxicity, but may be slightly less effective. In the era of targeted therapy, streptozocin 5-fluorouracil chemotherapy still has a role, particularly in well-selected patients. This brings us to the ECOG-ACRIN E2211 trial, one of the most important studies in NET management. In this randomized Phase 2 trial, 144 patients with advanced low or intermediate grade pancreatic NETs were given either temozolomide alone or temozolomide plus capecitabine. The combination demonstrated superior progression-free survival with a hazard ratio of 0.58. Let me explain what this actually means. Patients on the combination therapy had their disease controlled for longer before it progressed. The combination showed a response rate of 40% versus 34% for single-agent treatment, with overall survival trends of 58.7 months versus 53.8 months. Now, you might be wondering about side effects. Temozolomide is an oral medication, an analog of dacarbazine, while capecitabine is an oral form of 5-fluorouracil. This means treatment can often be taken at home, rather than requiring intravenous infusions, though regular monitoring remains essential. An important detail for discussion with your doctor: MGMT expression, that is, O6-methylguanine DNA methyltransferase, may predict response to temozolomide. Some studies suggest MGMT deficiency correlates with a better response, though testing isn't yet standard practice everywhere. If you're supporting someone through this decision, understand that the ECOG trial included patients with Ki-67 up to 20%, meaning grades 1 and 2. More recent data shows response rates of 36% in grade 3 tumors, though results favor well-differentiated NETs and those with Ki-67 below 55%. Now let's talk about when NETs behave more aggressively. Poorly differentiated neuroendocrine carcinomas, abbreviated as NECs, represent a different category entirely. These are high-grade tumors with Ki-67 exceeding 20% and a poorly differentiated appearance under the microscope. For metastatic digestive NECs, carboplatin in combination with etoposide is the recommended first-line treatment. Based on small cell lung cancer protocols, this combination achieves response rates of 30 to 50%, with progression-free survival of 4 to 6 months and overall survival of 11 to 12 months. Here's something crucial to understand. Immediate disease progression without benefit occurs in up to 30% of digestive NECs and up to 60% in colorectal NECs specifically. This is significantly higher than the 5 to 15% typically seen in oncology. If you have a colorectal primary, the median overall survival is only 7.6 to 8 months, making this one of the more challenging situations. Two recent Asian randomized trials compared cisplatin etoposide versus irinotecan cisplatin in metastatic digestive NEC finding no significant differences in response rate, progression-free survival, or overall survival. Both regimens showed similar severe adverse event rates but different toxicity profiles, with irinotecan causing less bone marrow suppression but more diarrhea. You can do the math here. Response rates matter, but stable disease also counts as a benefit. In the Nordic NEC study of 236 patients, response rates to Platinum-Etoposide ranged from 30 to 50%. But here's the key perspective. For pancreatic NECs, this appears more favorable than for other primary sites. For Temozolomide-Capecitabine in pancreatic NETs, the ECOG trial showed a 40% response rate with the combination. In a retrospective study of 30 patients with locally advanced or liver-only metastatic pancreatic NETs treated neoadjuvantly, the response rate was 43%, and 87% subsequently underwent surgical resection, with 63% alive at 5 years. Now what does this tell us? In carefully selected patients, chemotherapy can facilitate surgical options that weren't initially possible. For grade 3 gastroenteropancreatic neoplasms treated with temozolomide-based therapy, response rates were 36% overall, with better results in well-differentiated NETs, 41% versus 26% in carcinomas and in tumors, with Ki-67 below 55%, 39% versus 14%, if Ki-67 exceeded 55%. If you're worried about someone you love with NET G3, remember that these tumors represent a spectrum. Some NET G3s, particularly those with Ki-67 between 20% and 55% and well-differentiated morphology, respond better to alkylating agent chemotherapy than to platinum regimens traditionally used for poorly differentiated carcinomas. Document your tumor characteristics precisely. Get copies of your pathology report showing the exact Ki-67 percentage, the grade G1, G2, or G3, and whether it's described as well-differentiated or poorly differentiated. These specific details determine which chemotherapy regimen is appropriate for you. Track your disease progression timeline. Note when your NET was diagnosed, when you had scans, and how quickly it's growing. Chemotherapy becomes more appropriate when there's progression within 6 to 12 months or less. Create a simple timeline document to share with your oncologist. Research treatment centers with NET expertise. Neuroendocrine tumors are rare, and chemotherapy protocols vary. Centers with dedicated NET programs will have more experience with the nuances, like knowing when temozolomide-capecitabine might work better than streptozocin regimens. Given my Ki-67 index of X% and grade differentiation status, which chemotherapy regimen do you recommend and why? This forces a conversation about whether you fit the criteria for streptozocin-based therapy, temozolomide combinations, or Platinum-Etoposide. What are the expected response rates and progression-free survival for my specific situation? Remember those numbers we discussed. 40% response for temozolomide-capecitabine in appropriate pancreatic NETs, 30 to 50% for Platinum-Etoposide in poorly differentiated carcinomas. Ask how your specific features might affect these expectations. Should we test for MGMT expression before starting temozolomide? While not yet standard everywhere, MGMT deficiency may predict a better response to alkylating agents like temozolomide. Some centers routinely test for this. How will we monitor response and how often? Guidelines recommend abdominal imaging every 3 months during chemotherapy, with earlier scans if clinically indicated. Understand what constitutes progression versus stable disease versus response. What are the specific toxicities I should watch for with this regimen? Streptozocin can cause kidney toxicity and nausea. Doxorubicin affects the heart cumulatively. Platinum agents cause bone marrow suppression and peripheral neuropathy. Temozolomide can cause blood count drops and requires monitoring. Know what is specific to your treatment. If you have pancreatic NET with Ki-67 above 10% and progressive disease, this combination suggests you need specialized chemotherapy evaluation, not just somatostatin analogs. If you've been diagnosed with grade 3 gastroenteropancreatic NET or poorly differentiated NEC, these require urgent oncology referral for systemic therapy as they typically progress rapidly without treatment. If you're experiencing rapid clinical deterioration or urgent symptoms, chemotherapy may need to start quickly in high-grade tumors causing complications. Let me quickly recap. Chemotherapy for NETs isn't automatic. It's reserved for specific situations, including progressive pancreatic NETs with higher tumor burden, grade 3 tumors, and poorly differentiated carcinomas. Your next step: obtain your complete pathology report with Ki-67 index and tumor grade. Then discuss with a NET specialized oncologist whether chemotherapy fits your specific situation. This information is for education. Always discuss your individual circumstances with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. All links are available in the description below. Thank you for watching.